Okay, so we've got some questions from the audience, but as the person moderating this, I've just got a couple of questions myself, and so I get to put my questions. First of all, suggestions. Nigel, I've got a suggestion for your SMSing the people before they arrive. The hour, that's really great because it's fresh in their mind. I wonder if we're all being over SMSed by everything now. But when they arrived, instead of being given a piece of paper, being given an appointment in with the practice nurse to get their vaccination while they're waiting.
Can I comment on that? With the primary sense reports, it can tell you when the practice visit is booked from the patient, and it can tell you if they've got a practice nurse appointment, and it can tell you if they're eligible for 10990s.
Yeah.
So that might be a solution.
Which brings me up to one of the online questions, which was about funding for nurses. There is no, if the patient sees the nurse and nobody else there, yes, there might be the 10991 if they have an active care plan, but there's no other funding for them. The GP has to cite the patient, and we have this mixture. The pharmacy is getting an amount. The person who was doing the council clinics gets just generalised funding. So we've got all this, we really all need to be funded the same way. We're all trying to do the same thing. Rod talks about how they took away our $18 payment for notifying, I think it was $18 for notifying childhood.
$6 for notifying, 18 for ownership.
Yeah, so now we just get multiples of 6, and for some reason I've been in the same practice now for nearly 5 years and I still get it in 2 lots, so I don't understand that. But you know, it's $6 doesn't go very far to all the work. And I loved your slide, Angela, about practice nurses are angels. I've sent that to my 2 practice nurses and my best friend who's a nurse, and I've already had replies, so I'm sorry I shared that. So I can see we've got lots of questions. So John, you were first.
Reminders are a complex beast. The evidence has been around about 30 years. One of the factors which I think both Lisa and Nigel have highlighted is they forget about the amount of GP or practice nurse disposable time. That's the time over and above they may have to deal with an issue other than what the person's come in with. And that varies from -2 hours if they're really running behind on a Monday, and at best about 5 minutes. The sweet spot's about a minute. So the issue around it is that the immunisation is a relatively simple thing to do. And yes, people can be vaccine hesitant, but the group you're talking to will largely accept it. The next level of complexity is asking about something like about smoking, because there's a bit of sensitivity with that, but that can be done in a minute. But then there are other topics. So the question is to Lisa, asking about bullying and bullying within families, which most GPs don't ask about, and is the commonest form of family violence. How can we pick that up? There's no mandate to do that, so we don't have good guidelines. So it's not an immunisation issue, but the amount of time that you're going to intervene, the kind of hassle factor and the various Pandora's box things you're going to open up are going to be problematic. The question behind all that, Lisa, is, as I asked you the other night there, we don't yet have a mandate, but we have no idea what GPs are talking about in terms of bullying and bullying going on in family violence. And half the parents are actually not aware of that. And so if we can actually measure how often that comes up in the discussions in the sort of data that you get, then we at least start to get some data and do some of the teasing out the way that Nigel did with the vaccines and using things like SMS reminders to prompt people.
So I guess that's a good advocate for GPs and healthcare professionals coding. And so, you know, I often am coding a lot more now because I've seen the value, obviously, and I teach my registrars that information. But with Primary Sense, it can look in some of the free text areas. So even if there's not been a code, we can use it to analyse. And at the PHN on the Gold Coast, we did look at domestic violence and some areas around that because that's often not coded. So I think that's an interesting emerging area of need, and you know, something that we could look at in the future.
95% of women would like their GP to ask about that. 95% of GPs don't.
Yeah, I think it's interesting, isn't it? Because we ask now all our pregnant patients, do you feel safe? Are you safe at home? I know maybe we should be doing that with our children when we're vaccinating them and doing our health checks. We should be, you know, somehow saying, you know, how's things at home? Do you feel safe at home? It's an easy question to ask.
But that's the disposable time. If you're running behind, the last thing
correct. It's the perverse lever. It's why I probably earn less in my practice compared to some of my other colleagues. And I think that at the end of the day, you've got to be able to lay straight in bed at night, and you've got to be true to your own values. And, you know, I do hope that there is going to be more investment into primary care, and with the strengthening Medicare task force, we are going to be funded to look at things like frequent flyers to hospital, frequent presenters. So, you know, things like mental health may well be seeing some increased funding coming due to that.
But John, can I just add that we didn't expect the person to be immunised at that consultation necessarily. It was just a matter of the GP backing up that SMS message with a recommendation that they get it, and maybe arranging an appointment to see the practice nurse or having it done at a later time. Now, we don't know. We can eventually do trials to examine that.
So you could see from the primary census data, 22% of vaccinations were done on the day if those high risk patients had a prompt by their GP, and then up to something like 40% extra in the next month. So it's the way general practice works. Sometimes we've got time, sometimes we don't.
Yeah. And yeah, I just echo that. I mean, that's where I find our practice nurse, particularly with the chronic disease plan, she's putting things up, not just in the prompts, but she's putting them up in the action list. What vaccinations have you had? What health checks like cervical screening, bowel screen, things like that. So I think it's all back working together. So I have a question.
Hi, my name's Kendall. I'm from Western New South Wales LHD. I'm a clinical nurse consultant in immunisation. My question is for Brenton. I'm just wondering, I'm a big advocate for pharmacy to be vaccinating. I think we should be able to put vaccinations in arms wherever we can on a population health level. My question is, it feels like it's been rather rapid for pharmacies, the implementation. Do you feel like pharmacists on the ground have had enough training as far as cold chain, APHIS, incorrect administration of vaccines, all that sort of stuff prior to all of this coming in?
Yeah, look, it's a great question. We've been vaccinating for the best part of 10 years now. And at the time in 2014, it was controversial that we were vaccinating 18-plus-year-old people with a flu vaccine. So we have come a long way. As I said in my talk, I think we've blossomed a lot through COVID. We're really well supported by our society and our college in terms of education. I know Angela, for example, is one of the nurses that really brought these practice changes through and educated. You know, when we had to upscale our workforce, we actually were taught by the nursing fraternity, which is great. So I think, look, yes, clinical governance in pharmacy is better than it ever has been. And there's actually a whole bunch of work happening behind the scenes right now to refresh it even more up to the modern standards. And that's about to roll out in the next sort of 6 months. And I know that from my work as a chief pharmacist. So yes, look, honestly, I do. I think the average pharmacist has done a cracking job keeping up with not only the scope expansion, but doing it safely and professionally. And it's only going to get better moving forward. The other good thing about scope of practice is very quickly is it's individual to a practitioner. So it does change based on knowledge and regulation and all that sort of thing. So pharmacists, like all professions, must stay within the boundaries of that scope for sure. Yeah.
Yeah. Question over.
I just had another question about immunising in the pharmacy. Are you able to access the patient's immunisation records on AIR?
Yeah, absolutely. It's been there for quite a few years now, and it's great that it's obviously now mandatory for everyone that uses it. So yeah, we have absolutely a total view of the patient's AIR in real time. Our vaccinations, when we administer them, are uploaded basically instantaneously as well. So yeah, I think, you know, we're part of that heavy lifting workforce. Yep.
So which brings me to an air question that I was going to ask Lisa. You mentioned about the fact that your software anyway, can only pick up the immunisations recorded in best practice. Now, my best practice, I can click on and I can see air. So this data mining doesn't actually sort of go through.
No, it's
that.
something we've requested and hope to have on the roadmap, but not currently funded.
Yeah.
And I guess it's a wish list. So if there's anyone from AIR here, we'd be really keen, because it means that 11 million unique identifiers will be cross-matched with their AIR records, which will save money, save time. You know, every minute I spend in general practice checking an immunisation record and right-clicking to make it go into my record is a minute I could be using to promote vaccines.
A colleague in my discipline, Dr. Oliver Frank, is on the IT committee for the college, and he's been in discussions with the Commonwealth for some time about having automatic updates going both ways.
Yeah.
Because what we administer in general practice goes up automatically, but we don't get an automatic download. It's quite feasible. They're concerned about the overload to the system.
Mm.
But as we point out, we don't have every patient attending all at once in general practice around Australia. It occurs over time.
Yeah, yeah. I just think that's one of the best things that I now have on my thing, that I can actually, patients in front of me and they can say, oh, I think I don't know how many COVIDs I've had, doctor. And I can see it. Unfortunately, did somebody say something about right click and it goes into my software?
Yeah, so right click, you can say.
Oh, right. Instead of typing it
But
in.
you got to click every immunisation.
Yeah, I'll practice that when I get home tomorrow. Rod.
My question was about the extraction, and I agree it's one of the rate limiting steps is that for us to go and look at 60-year-olds who've been fully vaccinated, we actually have to go individually to make sure that they haven't had their vaccine somewhere else. One of the difficulties of having the vaccine somewhere else. So I put a plug in to say we need to be able to extract on a practice basis, so I can actually search in my practice to make sure, because just because my data says they've been vaccinated, I don't know, because I can't extract their Australian immunisation data. So that limits it, increases the time, and is sabotaging Australia's rollout. So we need to change that.
So I think we should make it an action from this meeting that we do approach AIR and make sure that the records go straight into the main software providers, BP and MD, but also with data tools like Primary Sense and PenCS and Polar.
Ken Griffin from the Australian Primary Healthcare Nurses Association. COVID's had some really interesting impacts. You go to New South Wales and they're using first-year dietitian students to vaccinate in clinics and that. I'm not suggesting for a second that's how we do, regular vaccination programs or anything. But some of the interesting things that came out of that is we, for instance, trained more accredited nurse immunisers as a country, and we've got more of them in the country than we've had at any other time in our history. But having gone through COVID, we've expected them to just go back and do whatever, and there's been no tracking of that. My question is actually for the whole panel, which is, given that this has been set up largely under different professional disciplines, where do you see for your disciplines the opportunities to improve uptake now, given what we've learned in COVID and given the knowledge that you brought to the table today?
You've got the microphone, Lisa.
Strengthening Medicare is supposed to be funding MDT teams, and so practices will be getting grants for nurses in practice and other allied health. RSCGB has been really advocating for pharmacists in general practices to also be allowed to immunise. Currently, they're allowed to immunise, but not. I think it has changed, hasn't just changed, that pharmacists can now immunise in general practice, but couldn't last year. So I think that funding is coming for the MDT team approach in primary care, but there should be, additional funding.
The primary health networks, some primary health networks have been tasked to place nurse practitioners within general practices. So in South Australia, in the Adelaide region, we've been tasked to do 4. So, it's great that we're moving. Could have been done probably a few years ago.
I think for me, it's interesting today because we're all kind of indicative of work at the coalface. And even though we hadn't seen each other's presentations, thematically, there was a lot around consistency. Funding was big, breaking down regulatory barriers. For me in pharmacy, in my context, it's getting rid of we've got a siloed workforce based on jurisdictions. That's the reality. So if we can break that down using some of those levers, that's going to make a massive difference to our consumer offer. That's what I brought it back to for me. How do we take consumers on a journey that ends up with a vaccine in their arm? So that's my response.
My response is that I'm a fan of the Blue Book. Maybe we should have a grey book for those over 65, which the person or their carer could actually, maybe an electronic version so it can be updated. Maybe a rainbow book for the LGBTQI community. I'm being a bit fanciful, but if you get the concept, it's about activating patients or people, individuals and families to do something about their own health. We've got managed care organisations in America. They do it for a different purpose. We should be doing something similar for our own population in a way that's acceptable. I don't know, young people are very good on their phones and they could have a similar thing. There's not that much that we need to consider there, but there are some. So look, it's just a thought.
Do we have any more questions? I think we had a couple of online questions and I think they've been covered by either the topics or the questions that we've actually asked. And I think certainly messages that come out of that, and Brendan summed it up nicely about,
Well, I was just going to make the observation of how well the four of you are working together. And maybe meetings like this need to occur more commonly, you know, to get that sort of kumbaya.
yeah, because, and
So Nigel, since the 6 months to 5 years or less than 5 year influenza vaccination was introduced in 2020, and we had 44% of kids vaccinated, we're now down to 28%. How do we reboot that?
The primary sense prompt is coming this year. Talk to your PHN, get it in South Australia. South Australia doesn't have primary sense at the moment as their data tool. So when a patient presents to their nurse, they all get a prompt at the nurse station to say this patient's due for immunisation for flu or any other childhood vaccination and meningococcal B across the country, whether it's funded in your state or not. And that's coming in the next month or two.
I think it is about initiation, and that at 6 months, if we possibly can. I mean, it is about having it in the blue book, because we need better mechanisms for immunising those children who turn 6 months or whatever outside of the flu season to get them started and have that journey. And then for people to be made aware of the risks that young children have in terms of influenza. Fortunately, we weren't faced with the situation of lots and lots of young children getting influenza and ending up in hospital. I know that the death rates were reported for, was more than expected, but that was across an age range up into the teenager years. So we've been lucky, but that won't always persist.
I'm quite glad.
oh, just can we wait till the microphone for the people online, please?
Thanks. I think when you're talking about increasing flu vaccination coverage rates in kids, you've been talking a lot about strategies to overcome access barriers, which are essentially reminders. And we know that they're extremely effective, but there's all the acceptance issues as well, misinformation, vaccine hesitancy, and no reminders are going to overcome that. So whenever we think about strategies, we really need to think about the communities we're trying to target and the groups, including Aboriginal communities, different culturally and linguistically diverse communities, and the strategies to overcome uptake in those communities are community engagement, grassroots approaches, mobilising community leaders, faith leaders, young people. So I think whenever we talk about improving coverage or uptake, we really need to be thinking about what the drivers are. And if it is practical issues and access problems, then, you know, reminders and complacency, that's fantastic. But I think it's a lot more complex, as we all know, which is why it's still sitting at 44% and dropped through COVID. So, you know, I know I'm preaching to the converted. You guys do this every day, but it's really important to consider both buckets of drivers, which are access and acceptance.
I think we've definitely been mindful on the Primary Sense Committee to have a broad representation group from practice nurses. We had an Indigenous representative. We've got university representatives such as Nigel, grassroots GPs. So I think it's real, and practice nurse, practice managers. It's really important to have that full MDT team approach. Primary Sense can have a link to really useful information. So we noticed that the meningococcal B prompts were only getting a 10% response, whereas everything else was 75%. And that was for Indigenous populations. So that obviously told me that we didn't have our prompts right. They should have been more appropriate for the Indigenous population. They should have linked to more Indigenous bespoke handouts. And so that sort of stuff is in the pipeline for ongoing promotion, because we know one of the best indicators of whether a patient will uptake a vaccine is if their healthcare professional, depending on, you know, anyone from the MDT team, recommends it. And so hopefully those sorts of tools will assist.
Yeah. Okay, so I think afternoon tea and the coffee cart is luring us, but yeah, I just think your messages, the consistency, clarity, collaboration and common sense are really important, and of course funding overpins all this. So thank you.